So this is video 2 of our cancer lecture. This is all about cancer treatment. You can see here that there are many different ways that we treat cancer, from the oldest to some of the newest stuff. So let's get to it. So the goal of cancer treatment really is, the first goal is to cure, to completely eradicate the cancer. However, not all cancers can be cured, and sometimes based on the type of cancer, might not be something we can cure, or based on the patient factors like their expected lifespan and some of the other things. It's a very individualized sort of decision. So what defines a cure really does vary based on the type of cancer that we're treating. If we can't cure it, the next thing we want to do is control it. So these are the cancers that would respond to treatment but cannot be completely eradicated. And if those fail, or perhaps the cancer isn't amenable to them, the palliation is relief of the symptoms, control of the symptoms. So the goals can encompass any of the treatment modalities that we saw on that first slide, which again you can go back to. But we're going to take a deep dive into some of these types of cancer treatments that we have, okay? So the first one that we'll talk about is surgery. So surgery is the oldest form of cancer treatment. There are very few references of cancer, again, prior to, I want to say, like the mid-1800s. But even as far back as the Egyptian times, I believe there was one, one reference to cancer, to a mass that was by one of the doctors of the time. His name escapes me, but who knows, in class I might remember it. But in the hieroglyphs, they saw like cancer mean and basically cut it out. So it's the oldest form of cancer surgery. May be done prophylactically to prevent cancer in known high-risk populations. So if that's the case, that's one type of surgery. We may use surgery to get the biopsy that we need to diagnose cancer. Surgery can be done alone or in conjunction with chemotherapy, both before and after. So the way to remember them is neo. And neoadjuvant means that the treatment is done before surgery, and adjuvant is after. So whether somebody has radiation, would be like neoadjuvant radiation. So that's the way to remember those. And then we may use surgery for palliation, things that might actually support the person, relieve their symptoms. So things like feeding tubes, Ommaya reservoirs, pain control, any of the orthopedic surgeries, even debulking surgeries might be considered palliative. So here's some of the surgeries, right? So debulking, when we say that, what we want to do is decrease the tumor burden. We can do this to make our treatments more effective, meaning less cancer cells that have to be destroyed. Local surgeries, those are usually outpatient. They're just small areas. Wide or radical, so we'll talk about this more under our respiratory unit when we talk about radical neck dissection. So basically that's when we're taking lymph nodes out and surrounding tissues. And the thing to know about these are that they tend to be very disfiguring surgeries. A salvage surgery, a salvage surgery means that you've got a recurrence after your initial treatment. So basically your treatment didn't work. So the example here is that if I had a lumpectomy, like we took out a lump from my breast and then I had recurrence, then my salvage surgery would be the mastectomy. And then we have reconstructive surgery. So sometimes in the case of some breast cancers, we might have reconstruction done at the same time as the actual cancer surgery. So again, a decision left up to the patient and the doctors for their best outcome. This is a little nod to our minimally invasive techniques and why we might use those. So this picture you see here is something called a VATS. It's a video-assisted thoracoscopic surgery. Because when we do thoracoscopic surgeries, there's two different ways that we can basically get to the chest cavity. One of them is through the front, through a sternal incision or a sternotomy, and the other is lateral on the side. And so this is probably the most common chest surgery you're going to see for lung cancer, the VATS procedure, and that's what this patient is having here in this little picture. So we do VATS because that the person has less healing, less chance of complication, less bleeding, shorter hospital stay. So they come back to their baseline a lot faster. So again, VATS and some of the other minimally invasive surgeries you might be familiar with, like robotic surgery. Instead of doing a laparotomy, we might do a laparoscopy. So those are very common in those pelvic surgeries. So that's a VATS. And now let's talk about chemotherapy. We'll talk about chemotherapy a lot through this, and it'll be in our next lecture as well. So basically, chemotherapy is systemic chemical therapy for neoplasm. So it's used to treat systemic disease rather than tiny localized lesions, but it can be used for pretty much any cancer that's out there. It eliminates or reduces the number of cancer cells. And here you can have different types, and we talked about neoadjuvant and adjuvant. So whether or not we're doing surgery and when the chemotherapy is used, we'll let you know what term to use. So our chemotherapies target cells in specific phases, so whether they're dividing or resting. And this is why we often need multiple agents, because remember, not every cell divides at the same time, and just because a cell is dividing today doesn't mean its neighbor is. So this is why, again, multiple agents to kind of break through the defenses of the cancer and destroy those cells. Multi-drug treatment targets more than one pathway and is overall more effective. Some people say the words like synergistic. And treatment is most effective when we have a low tumor burden, uninterrupted therapy, and that we have an adequate dose received. So there are different reasons we might not get an adequate dose, and those would be the effects of chemotherapy. The side effects are usually the limiting factor and whether or not a person continues with chemotherapy. And there are multiple types of drugs that we use for cancer. I will give you a handout in class, and just trying to peek through the rest of our stuff here to see if I have it here. I really don't think I do, but we'll talk about them briefly, and I'll give you that handout in class on the actual drugs. So we have things like alkylating agents, which break the DNA strand so it can't divide. Antimetabolites, those work in the S phase, and they interfere with functions. And we use antimetabolites in other conditions like rheumatoid and sickle cell and lupus, so some of the autoimmune disorders. Anti-tumor antibiotics, they bind directly to the DNA, and your NCLEX will be full of drugs like these, I think. Like if you're going to get any, those would be them because they're antibiotics. You have one listed here, adriamycin. That's an anti-tumor antibiotic. We have mitotic inhibitors. So those arrest mitosis. So things like vinblastine and vincristine. The platinum drugs, they end in the platin, so cisplatin, carboplatin. They bind to the DNA and the RNA. And then nitrous ureas. The exemplar drug here is carmustine. The thing that's neat about that is that they're cell cycle non-specific, so they work in every phase, and they actually cross the blood-brain barrier. So a lot of different meds we just discussed. I'll give you a handout. So let's talk about chemotherapy. basically, chemotherapy does not know the difference between a regular cell and a cancer cell, right? It just targets the cells that are in that cell cycle that it's meant for. But in general, the most rapidly dividing cells are the ones that are going to uptake the chemotherapy the most. And because of that, you'll see the exertion of the cancer therapy on the normal cells as well as the cancer cells. And we do have several drug-specific adverse effects, and we have some that are just in general just because they're chemotherapy. So we could have acute, meaning that the adverse effect happens right with the administration. Delayed, which means it doesn't show up right away. It could be weeks, even months or years down the line. And then chronic, those are the ones that the person will be living with. All right, so preparation and handling of chemotherapy. You, as a brand new nurse, should not be handling chemotherapy. Basically, you need to be specifically trained and competent. This is a major, major occupational hazard, both the medication and the patient's excretions following chemotherapy administration. So this is why you need to be trained in order to do this. Administration, many different ways. IV is the most common, and many are vesicants or irritants, and they may cause extravasation, which we'll talk about in a minute. Some by mouth. So if you're giving something PO, you need to know the proper use and storage of the medication. That's just safety. Regional. So we might see those as intra-arterial, intraperitoneal, intraventricular, intrathecal. So why might we do regional? Less systemic toxicity. So intra-arterial is when we deliver it to the tumor via a specific artery that might be feeding the tumor. Intraperitoneal is in the abdomen. Intrathecal, intraventricular, that's in the central nervous system. So for those, you might need like the lumbar puncture or the Ommaya reservoir. Intravesical is the bladder. Very, very interesting. You basically put a catheter in the person's bladder and instill the medication and then kind of have them turn at routine times, leave it in place for 1 to 3 hours, and then drain it out. So one of the things I'll say over and over again is that if you have regional chemotherapy administration, you don't have as many systemic effects. So regional administration means regional effects. So think about that. Use your critical thinking to let you see what that might mean. So if I'm giving something intraperitoneal, where am I going to see the side effects? If something's being given in the bladder, where might I see the side effects? So extravasation, that's the next thing we'll talk about. So extravasation is really, like I said, many of these are irritants and vesicants. So if we're giving them peripherally, this can be a huge deal, right? So you can see there's a picture of what happened. You could see where the IV was placed and what it did to the tissues beyond. So if that IV becomes infiltrated or leaking into the tissue surrounding it, some of them are absolutely destructive to the tissues. This is the reason that depending on the type of chemotherapy that's going to be given, many of our patients have venous access devices, which are often called metaports. I think it'd be like having jello or gelatin. So metaport, PICC lines. We have some of the newer stuff like midline catheters, which basically, for all intents and purposes, function like a very long peripheral line. So what happens if the person is having extravasation? First, stop the infusion, right? That's number one for a lot of things. If something bad is happening, stop the bad thing. Second, do not take out that IV catheter, because if the fluid is leaking into the space you take it out, you may not get back there because of the swelling or the tissue destruction, and there may be an antidote. So don't take that IV out. Basically, sometimes you aspirate, like pull back on the line. So whatever is still in that line that's there, pull it out. Get as much out as you can. You might have access to an extravasation kit, any of the medications to treat, and then, of course, letting the doctor know. So that's extravasation. All right, we'll go a little bit back to chemotherapy regional administration. We've talked about this already, just a few slides, but here it is. Regional administration means regional effects. See that there? All right, so hormone therapy. We use some hormone therapy as an adjunct to other types. We use it a lot in some of our breast cancers, and we can use it to block hormone action or enhance hormone action, depending. We'll talk about hormones more during breast cancer, but basically to know that we do hormone therapy. Immunotherapy, using biologic response modifiers. So basically, when you see immunotherapy, what we are trying to do is recruit the host, so the patient's own immune system, to fight against cancer. So at the end of the day, the immune system is what takes out that last cell, right? So things like interferons and interleukins, right? Though interferons and interleukins, they have many properties that are very desirable in medications. We use monoclonal antibodies. So antibodies, remember, those come from beta cells. We might use targeted therapies, which might be targeting like a specific enzyme on a cell surface. And then bone marrow and stem cell transplants. That actually would be sort of, we'll talk about it separately, but it is enhancing and using somebody's immune system, correct? So it does kind of belong there. So interferons. So the difference between the interferons and the interleukins are kind of like listed here. So basically, interferons have antiviral, anti-tumor activity, and then the interleukins are signals to the other cells. Interferons can interfere with angiogenesis, which is the proliferation of new blood vessels to a tumor cell. And they can directly destroy the tumor cells. So one of the things with these medications, especially like interleukins, but you may see it with the others, is when you're giving them is the flu-like symptoms, right? And also capillary leak syndrome, right? This is a big deal. So when our capillaries are leaking, that means fluid is leaking. So you end up with pulmonary side effects. So if you see signs of capillary leak syndrome, that is a reason that we would not want to continue with that. So how would I know somebody's got capillaries leaking? Right? You might need to listen to those lungs and listen for crackles. So hypotension, oliguria. So anything from flu-like symptoms, which we can treat with normal flu-like treatments, Tylenol and such, versus all the way down to capillary leakage. So monoclonal antibodies, they are targeting different types of cancer and on the protein. So you could see here's like a little bit of a picture of the antibodies, which basically makes it easy, like setting up a flare for the immune system to find these cancer cells. We even have some really cool ones where you can actually even give radiation right to the cell. So rituximab. So how do I know the mAbs? They say MAB at the end, the monoclonal antibodies. And sorry, I don't know what that sound was on the computer, but hopefully you didn't hear it. So they say MAB at the end. So that's how you're going to know you're dealing with a monoclonal antibody. One of the reasons we don't use them as often as we do is because of the side effects. They can cause hypersensitivity reactions, so anaphylaxis. So, all right. And then here's just some of the targeted therapies. And I don't expect you to remember all of these, but some of the things we might be targeting or using would be those that stop angiogenesis, some that stop tyrosine kinase. So just different ways targeted therapy acts. And remember, our immunotherapy and targeted therapy can also cause anaphylaxis, flu-like symptoms, lots of different problems. Remember, side effects, when you're giving these, they occur acutely. And if you stop, then the side effects stop, right? So, but they may impact a person's decision to go on with therapy or not. So, next thing we're going to talk about is radiation. So, the goal of radiation is to provide radiation to the tumor while sparing the surrounding tissue. So, basically, it goes after actively proliferating tissue, like things like the GI and the bone marrow. See, those would show the earliest response if we actually put radiation to those areas. Slowly proliferating tissues, like the bone itself, kidney, those show later responses to radiation. So radiation in general, though it can be used widespread, is generally used locally. So remember, if we have a local treatment, then we have a local effect. So let's talk about it. So not a primary treatment for systemic disease, which makes sense, right? Because you don't want to radiate the whole body, but it could be used to treat primary tumors. We generally will give radiation for, this is in general external beam radiation, delivered over 2 to 8 weeks. And then there's something called simulation. Simulation is when the radiation treatment fields are worked out. Basically, the skin gets marked. You might fabricate those devices. I'll slide you back up here so you can see it. You see that they made that device during simulation to hold the person exactly still where they were. And as far as nursing care for any simulation, if they have any marks on their body, please do not wash them off. So external beam radiation is literally going to be the most common you're going to see. It's got really, really super pinpoint accuracy. And basically, your healthier tissue can regenerate in between your dosing. And you see here this picture that's in front of you. It's just to let you see how we can hit a tumor 3 ways without going through the tumor through the same spot every time. Because the problem with treating some of these cancers are the organs that are in the way of the cancer, right? So if I have a mediastinal mass, I might be radiating my heart, my lungs. So again, think local treatment, local effects. Look at where we're putting the radiation. So how do we take care of the skin? Dry skin in the path of radiation, no lotions or ointments. Avoid sun. Avoid extreme heat and cold, so no hot packs, no ice packs. Loose cotton clothing. If a person needs to shave in the field, the treatment field, then of course it's an electric razor, only if necessary. Gentle cleansing, pat it dry, air out the skin if possible. And you can see the radiotherapy cycle here, like how it happens. Basically, we give the radiation, and then a couple weeks after, skin becomes erythematous, and then there's something called dry desquamination. So, or we can have moist. So the best advice I can give you as a nurse is something's dry, let it be, right? Don't moisten it if it doesn't need to be. That's different than pressure ulcers, like you want to have an optimal wound environment. But if the skin's intact and dry, even if it's red, let it be. if something's moist, then we often have to, we're more worried about like infectious risk, right? Because that's a break in the skin. So that you often will need to cover and treat. This is why we don't let people in radiation like do a lot of swimming, things like that. Got to avoid the infection risk. And then something called internal radiation or brachytherapy. This is one we implant, usually seeds, but we could do it other ways too. They could put a catheter and kind of just pass a radioactive implant nearby and then take it out. Basically, for these, a lot of it is dependent on whether or not we're using high dose or low dose radiation for the patient, as far as what sort of precautions we need. For the external beam radiation, that does not change how the patient is, right? They're not going to become radioactive. But brachytherapy, they may actually become a source of radiation themselves. So if we're using high dose. And therefore, we have to have some special considerations. So we might have, so let's talk about brachytherapy. It might be for a short time or a long time. So if it's short time, temporary brachytherapy, that is a really, really highly radioactive material that's placed in. And then permanent is when they're putting seeds in, and this is, you can see this as a prostate that has been seeded. Basically, the exertion of the radioactive force is so minimal that it doesn't go outside of the local tissues, so those people are not radioactive. So you need to know what you're dealing with, right? What if I instead had a rod placed, this is a prostate gland being seeded, but intraluminal, so catheters, interstitial. We need to have some safety protocols when dealing with people who have the high dose radioactive implants. So, and here they are. So, ALARA, as low as reasonably achievable. So this means that we need time, distance, and shielding. The biggest one of those guys I'm going to tell you is distance. It doesn't matter how much shielding you use if you're like close up. The shielding isn't be all. It's keep your distance, because that radioactivity can only travel a certain amount, and you need to be out of that circle as much as possible, whether shielded or not. But of course, some of the things we do as nurses, we organize our care together. So if I'm going to be doing a lot of things in the room, I want to have a plan, right? A plan to enter and exit. I always wear a dosimeter. You'll see people who work in X-ray department wearing those routinely. This can be very difficult for a person to deal with the time and distance limitations of the nursing staff. They often feel like they're left to their own devices, and honestly, they kind of are. So communicating with your patient from a safe distance is important. All right, and protecting our caregivers. So these are some of the principles of care that we can have for taking care of people. Basically, our radiation safety officer is the person that's going to tell us what's safe and what's not. Person deserves and needs a private room, private bathroom. We need a sign to let the other people know what's going on. If you have an implant that is dislodged, if it's gone out of the body completely, you need to use the forceps and place it in a lead-lined container. There are other times you may need to call the provider. I mean, certainly you have to call the provider either way, but that is a source of radiation, so never handle it with your hands. For people who have high-dose brachytherapy, no pregnant staff or visitors, because remember that radiation is exerting its force on those dividing cells, and fetuses tend to divide rapidly, and no kids under 16. If they do have a visitor, it's less than 30 minutes, at least 6 feet from the radiation. Those seed implants, the patients go home with really no risk to the others. And if you just have low dose radiation, no pregnant women or children as well, so they should not have And then radiation toxicity. So radiation toxicity is something that we need to just put a nod to, that usually it's localized reaction, but it can be systemic. This is the fatigue and anorexia, and most of the time the side effects will recede after the treatment or subside. But some of the other things that we can cause by radiation may exactly be permanent. So vascular supply, pulmonary fibrosis, cardiac, mental changes, all of that. So remember, based on where the radiation is going is what symptoms we're going to see. I don't expect somebody who's getting radiation to their knee to suffer alopecia, right? Because alopecia mostly is from brain radiation. The difference between chemo and radiation is that hair loss with chemo is basically reversible. Like once they stop the chemo, the hair grows back. But with radiation, it does destroy it, so the hair will not grow back. So that is the end of this second set. So we will pick up next with caring for patients with cancer. Thank you.